for discussion and debate everywhere, especially in our Learning General Surgery group. And there seems to be some polar differences between the students and the teachers. And we are most often we have the teachers and professors are the ones who are more vocal. And we felt that maybe sometimes we are not hearing the students' voices. So Dr. Ilanga Sethu and Dr. Pattarada Krishna decided to have this session where we will let our students tell us what they think we can do to improve the surgical training in India and in fact the entire Indian subcontinent. So Dr. Vinay Kumaran is supposed to moderate this session. He is held up in a surgery, but he'll be joining us shortly. So Ilango, could you just introduce Dr. Vinay and then a brief introduction of what are the points we plan to discuss today, and then we'll get on with the students.
So thank you, ma'am. To begin with, this topic has been very close to all the co-members of the Learning General Surgery group. We have heard horror stories repeated by several postgraduate students from across India about the differences, about the difficulty in getting a good learning experience out of general surgery and sometimes out of MCH courses as well. Right now, after they complete their NEET PG examination or the NEET super specialty examination, the key question seems to be talking to well-known seniors and approachable seniors, I would say, to find out what is good for them and where they can learn the best things and stuff like that. So this has become a sore point for all of us, and what better way to hear it out of the horse's mouth is what we thought initially. And while we discussed with several of the students and we listened to those horror stories one more time. So to moderate this, we actually took a firebrand and who unfortunately cannot join us. He's in the midst of a transplant surgery. So Vinay Kumaran is well known in learning general surgery. He finished his MBBS and MS general surgery from Maulana Azad Medical College in New Delhi, and he did a senior residency from the UCMS in Delhi. He completed his MCA GI surgery from the All India Institute of Medical Sciences at New Delhi, and then went on as a research associate. And I know that he was doing hepatocyte transplantation at the Marion Besson Liver Research Center at Bronx, New York. He then was a super senior to us at Tom Starzl's Transplantation Institute at the University of Pittsburgh during the LO years. He used to call it like that. I think Professor Amedio Marcos was the chief of transplant when he trained. He subsequently returned and joined as a surgical consultant in surgical gastroenterology and liver transplantation at Gangaram Hospital, New Delhi, and then subsequently became the director of liver transplantation at Gangaram, Delhi. He moved from Delhi to Mumbai and became the head of liver transplantation and HPB surgery at Kokilaben Dhirubhai Ambani Hospital and established it as one of the premier transplant programs in Western India. And he has also operated extensively in India, Cambodia, and Bangladesh. He currently moved back to the US and is now working as a professor of surgery in organ transplantation. And he's the surgical director of the Living Donor Liver Transplantation Program of the Virginia Commonwealth University in the Hume Lee Transplant Center. This is one of the first transplant centers in the world. And he also works at Indiana University. Okay. Can you? I am actually sharing Vinay Kumaran's slides on this discussion, and we hope the Firebrand will join us with our Firebrand panelists as well. So we can go into the topic. The plan Vinay had proposed is that how is teaching surgery during medical school? How is the surgery rotation during your internship? How is the selection process of residency? How is the surgical training during residency? What's the thesis? How about the exit examinations? What are the opportunities for senior residency? And how do you find a job or a subspecialty training? It's the general plan that he has planned for us. But we have some very, very interesting people to talk to us today. I think Dr. Sandeep Mulchandani is here. and he can use the slides to share his initial thoughts, and I will give over the podium to him. Thank you.
Thank you very much, sir, for giving me this opportunity. So first of all, I was not able to get the slides, but I have my thoughts ready on a piece of paper. So I'll be going extempore with that. So first, to start with my introduction, I am at the crossroad right now. So probably you might be thinking all the people who have been given this dais will be students. But I have last month joined as assistant professor for neurosurgery at Santosh Medical College in Ghaziabad in Delhi NCR. But I have finished my neurosurgery course last year, so it has been just a year. So I am at the crossroad, and I can probably speak from both the parties and probably frame the problem statement, and also suggest some solutions which can be helpful. And also I would like to introduce a platform which I run, which is called as World Surgery Forum, which I started as a blog in 2016, and since then it has grown quite popular amongst the residents. So with this backdrop, I will go with defining the problem. So what problem as a resident? So I have gone through a general surgery program. I have gone through a neurosurgery DNB program also. So I would be able to tell you the problems of both the programs and how we have to deal with them. So first of all, as we see what residents have been complaining, so their complaints are mainly they are always used for donkey work, they are used for paperwork, they are used for ward work, and even menial things like report collection. This happens because our hospitals are still very behind in terms of proper workflows, proper systems which can so there are many deficiencies. So reports, when they are produced in the lab, there is a significant lag time before they reach the main decision maker. Okay, so this has to happen via IT system, but that does not happen. So what, to fill that deficiency, what the HOD will do, what the assistant professor will do, he will send the resident, he will get his reports as soon as possible. So what residents are being used right now is to fill the deficiencies of the system. So that is one part of the problem. Second thing is the number of residents are increasing. As we all know, the seats have increased in past 5 years by at least 40 to 50%. So this is the second point I want to bring about, is that since the number of residents are increasing, number of medical colleges are increasing, and the patients are almost the same. So the cutting opportunities, the training opportunities obviously gets divided amongst the residents. So this is the second point of the problem. Thirdly is that, again, above the residents, there are big medical colleges, you have senior residents, then you have assistant professors who are also novices. So they also are looking for their cutting experience, right? So again, the resident is the sufferer over here, because the cutting which was supposed to be for the resident, maybe let's say final year resident who wanted a gastrectomy, or in neurosurgery maybe a surface glioma surgery, so that goes to the SR or the assistant professor who has recently joined. So this is where another opportunity missed from the resident's hand. Then as professors, as seniors, as you are all aware, the increasing landscape of litigations. So everybody today is not doing surgery with a free mind. So as in 20 years back, 30 years back, people were doing surgery and they were thinking that I am doing good for the patient, and if the patient is improved with my surgery, then I will be happy, patient will also be happy. But patient, even if there is some complication, but there used to be no scope for litigations. So people were ready to take risks in giving the free hand to the residents. But that is not the case now. Litigations are everywhere, and you see for even small things, we keep on reading court cases and big litigations running in 10 years, 5 years. So everybody is afraid, right? So this is from the perspective of a senior or of a consultant or a professor who is leading the training program. Now, talking about the attitude of the resident has also changed. Attitude of the resident is that he has to get the degree, and he has to do as many MCQs. He has to pass the exam. So pass the exam in the sense he has to pass his general surgery guy will think he has to pass the super specialty exam. The MBBS guy will think he has to pass the PG exam. Now, why this is happening again is that our exam don't cater to the clinical examinations. It does just caters to the rote learning and the cramming of facts from the textbooks. So if they say that general surgery, if you want to qualify for super specialty examination, you have to finish your Bailey and Love and you have to finish your Sebastian. So if a person has to do both, how will he be able to do justice to his surgical training and hands-on experience? So this is one other part of the problem. Then coming to the paying medical colleges, paying institutes and DNB institutes, there the patient are paying, and they expect that the operation has to be done by the surgeon in whose name I have come. So I will tell you one instance. I was under training in my DNB institute, and the professor, the senior consultant, he left the surgery, and by the time we were doing the closure, so in neurosurgery a typical closure will take 1 to 1.5 hours of dura closure, putting back the bone flap, then closing the skin. So that 1.5 hours rose a big suspicion in the mind of the patient attendants, and unluckily the patient had some complications, and patient ended up with some complications. So what happened is the patient brought at least 40 to 50 people, and they were full in attack mode, and their main allegation was that the senior guy, he has not done the surgery, it was given to the junior guy. So you can imagine the pressure on the professors and on the consultants who are in the paying institutes, who are in the institutes where the patient is paying in the name of the surgeon. He's not paying in the name of the residents, he's not paying in the name of the intermediary people, he's paying for that big name, right? So this is another problem which we have to look for solutions. So right now my focus is only on mentioning the problems what we are having. Then there is no facilities for intermediate surgical training. So surgical training is not just on the patients, right? Surgical training also comes when you are doing your simulation practice, when you are doing bowel anastomosis on a sheep intestine, on a goat intestine, when you are doing your vascular anastomosis on a chicken leg, when you are doing your suture practice on a foam pad. So these are all the surgical training opportunities we are not providing our residents, which Western institutes are using very often. I will tell you, not more than 5 to 10% institutes will have a wet lab, will have a skill training lab, functional one. They might have a empty room with a table and with one lab set, which they call it as a skill lab. But we don't have any big functional skill labs which are actually managed by a senior faculty and who is running any programs on that. Now second part of the problem is that we are also not having cadaveric training opportunities. So cadaveric training is another missed opportunity. So how will you raise confidence that your residents will not botch up the surgical procedure you are giving him chance at, when you have not trained him, when you have not given him any intermediate training? So that's why people are not confident. So bowel anastomosis, when I've given my resident, and he is first time he is suturing the mucosa, he is first time doing the serosa and all the layers. So it is the first time on the patient's body. So how is that support? How can I be confident in that situation? So there has to be some setup or some requirements from agencies whereby the intermediate surgical training in form of laboratory training, skill labs, cadaveric training, all those things have to be in place.
Sandeep,
Then
I apologize. I'm going to interrupt you a little bit because we want everyone to speak up. And if possible, let's follow the format that Dr. Vinay planned so that, we won't be repeating ourselves. We'll get different perspectives. Ilango, could you just put that slide back on
Yes.
for the first one? And Dr. Anjali, could you unmute yourself? We'd like to hear from you.
Ma'am, can we have GDS sir place his comments before Dr. Anjali comes in? I'll share the screen. GDS sir, we are waiting for your comments on Dr. Sandeep's thoughts.
Yeah, I am running. Am I audible?
Yeah, sir, you're audible, sir. Perfect. Sir.
Okay. For say more than 20 years, I agree with him. But if you have to call yourself worth a teacher, one has to have the courage of supervised cutting. I stand with my people, and I am the first assistant to the resident. I do not find, only thing is that the time taken is a shade more, but neither the patient suffers, and I am there till the skin clear. Then twice a year, I run a wet lab. We get the goat intestine, and on that, we divide in two halves. On day one, I spend 4 or 5 hours with them, and we teach. I mean, the boys do a ileoileal, a gastrojejunostomy, a colocolic, all on the fresh gut. And half of it we freeze, which they do it on the next day. So every person can put the seromuscular, the single layer clear as good as I can do it, and they are given ample time. So they keep repeating. This is the only way within the DNB program where the hospital is not interested to spend a rupee. We only have a teaching room where actually I pay for the goat gut. The boys procure it, and everybody has his instruments, and they arrange suture from here and there. And I find that is a reasonable, practical way.
That's actually a good survivor mode to whatever Dr. Sandeep was talking about. The creation of intermediary modes of training is also dependent on the resident. So can we just move on to Dr. Anjali for her comments, and then we will come back for our teachers' comments as well. Dr.
Sir, thank you.
Yeah,
am I
yeah,
audible?
Anjali. Yeah, you are.
Yeah. Hi, good evening, everyone. I'm very thankful for this opportunity to be here among the stalwarts of the surgical community. So I'm Dr. Anjali. I finished my PG training in Amla Institute of Medical Sciences, Thrissur, Kerala in 2019. And I joined Amrita Institute of Medical Sciences as faculty of general surgery. And I'm an assistant professor in general surgery now. So I was just listening to Dr. Sandeep Mulchandani sir's take on, especially because, like he said, he is in the crossroads. He's just finished his training, and now he's newly appointed as the assistant professor. And I think he very well, he's able to see both things from both perspectives. So it basically sums up my concerns as well. Actually, there's just a very brief thing I want to talk about, and that is probably mental health of the residents. It's just something that I personally I'm passionate about. It's just that from I think from the get go, from our MBBS time, from the time we do our medicine and everything, we are fed certain. There are certain perceptions that I think students have about certain fields, especially when it comes to surgery, and I think maybe that there's a maybe that is one factor that probably goads people, certain people, onto taking that specialty and probably dissuades others. And of course, when somebody, when some senior asks you that why do you want surgery, or what is the specialty that you want to do, and then you say surgery, and then there are some people who will be like, oh good, you're very brave for doing that, or some people will actually try to discourage you. And then I think the stress of taking surgery for some people, uh, it's no matter, it's by no means a personal account. It's just that I've seen some people actually get worked up very easily right from the get go because of that. So the stress level starts soaring right from there, from the time you've decided to join general surgery, as in from the time you've decided to take your exams, your NEET exams, or your USMLE, or whichever exams you want to do, wherever you want to go, your stress levels start from there. And then you join surgical residency, and you know that it's a lot of hard work. We all know that there's a lot of hard work. There's a lot of hours spent. You have to be on the campus 24/7. There are no excuses. But still, I think you're never really ready for it unless you actually go and join and you're there. And at that point of time, just like Ilango sir was saying, there are a lot of horror stories that I can recount and I have heard from my other colleagues from other medical colleges, where a lot of things have been said to them, or a lot of experiences have been incurred by them just because they're not mentally prepared for it. And how much ever we say that, I feel how much ever we say that, okay, as a surgeon, you must be, as a general surgery resident or as an AE, surgical subspecialty resident, you must be able to take that stress and be able to deliver despite that stress. I still think that some sort of a psychological support must be given to these uh, trainees, surgical trainees, if it is required, because uh, whether it's surgeons in training or even surgeons who are older, surgeons who are like I was saying, stalwarts in their community, even these people deal with stress, burnout, neuroses like anxiety and depression. And I think some sort of a system should be in place so that some sort of a psychological support, a mental health support is given to these people. And even if it doesn't come in the form of formal counseling, I think maybe having a more supportive environment for people would be okay, because of course things have changed a lot. It's not like people um, are it's not like anyone is, it's not like people are harassing people for the sake of it. That's not what I'm trying to say. It's just that maybe some sort of a psychological support for students, for surgeons in training, so that anyway the work is very demanding, the hours are very demanding, and we don't want people in training to burn out very soon. We don't want people to burn out very early in their career, because anything that happens, anything that adversely affects mental health, I feel will be translated in terms of patient outcomes as well. If somebody is very frustrated and cannot concentrate on what they're doing, especially in the junior level, I think it sets the precedent for how they'll function later on. And yeah, so basically, I just wanted to highlight this mental health concern, actually, because yeah.
Thank you, Dr. Anjali. your points are taken. Can
Would you like to come on now, Dr. VR? We'd like to hear from you.
Who's VR?
Vinayak Rangan? Vinayak, are you there? Can Dr. Puneet respond to Dr. Anjali's comments?
No, I think they're very extremely valid. I'm undergoing that with my son right now. So what she's talking about, the mental health, I didn't hear them completely because just texting the link and this thing to the group of kids who've just joined right now, because I thought they'll really identify with what she said. So I think we don't have the mechanisms of coping with the mental health is absolutely true. We don't even have for trained surgeons, forget about, trainees, yeah. But absolutely true. All the points that everybody said till now, whatever I heard was, really spot on, and we really need to. I was actually thinking of the, that for next time for the national board things, we should make sure that we actually, instead of looking at how many accountants and bathrooms are there, we should be looking at the wet labs and the skills centers and develop them, because unless we put them as requirements, they're never going to come up. No. So I think this is a very good training session for me as well.
Puneet, with Ilamo's permission, just a minute, because in this regard about mental health, this morning, a very close friend of mine is a senior surgeon. His son has joined specialty surgery in Delhi. He says, my son called and cried whole night to me. He says, I don't know the language. I can't manage the schedule. I want to come back.
Yeah, I don't want to repeat for fear of. I don't want to repeat.
This is a very major issue. See, somebody who's gone top specialty and calls back and cries, says, Papa, I want to come back. I can't withstand this pressure. I don't understand the language. Puneet, what is your take on that?
No, I can tell you a similar this thing, but because this recording is going to be seen, I can't repeat quite a bit of the stuff.
Okay.
So it'll be cringeworthy for many of the kids. In fact, while Dr. Anjali was speaking, I was just telling my wife, who's an ophthalmologist, that one of the kids, his friends, he was within the first 50 students. He just left ophthalmology because he said, I can't take this pressure of surgery. And he left it and has joined dermatology in RML or something. So, I mean, I think what she's saying is true. We need to take care. So I think many of us at the senior level have this feeling, oh, if they can't take this stress, then they shouldn't be in surgery. But I think it's a little beyond that, and we don't realize a lot of the stuff, because I'm seeing it firsthand in a very busy, thing. It's even people who are taking a lot of care don't realize how much more needs to be done. So I think it's a good, these kind of things act as very good learning exercises, and what you're saying is absolutely spot on. We do need to be aware of them and take corrective measures actually.
I think Anjali had a point that maybe they should know more about what they are taking on. Of course, the support will be needed once the decision is making and they're not able to handle the stress. But exactly what they are letting themselves in for, maybe that is also important for them to make the choice. I think that was another very valid point made by Anjali.
That's extremely important, and I think the reason they don't get that is because the internships for them are not real internships. So I have a hope that when the next exam comes, they're going to have genuine internships like we did. We had a 2-year post-graduation with internship followed by a 1-year house job. So, we knew exactly what we were getting in for. So what Anjali is saying may be absolutely right, because in their internship right now, they're only preparing for the PG entrance. So they have no clue what they're going to, be exposed to.
Thank you, Dr. Puneet. Santosh, would you like to say something? Santosh, you're here?
Yes, ma'am, I'm here. Am I audible, ma'am?
Yes, please.
Thanks, senior faculties and stalwarts for letting me talk in this forum, madam. So I'll just summarize in some 3 or 4 subtopics, ma'am. First is foremost is internship. Following a formal surgical beginning school in the medical school, internship is a very, very important thing where we actually deal with surgical patients. So that time, if professors or assistant professors are not able to take care, at least they should see that the senior PG is able to teach at least basic skin suturing or something to the intern. So by the time an intern comes out, he should be at least worth enough to put a traumatic sutures. So next, moving on to the residency program, once they have chosen, so I have divided them into the what we can expect from the mentors and what we should expect from the resident side and what we can expect from the national board or the examination side. So from the mentor side, it is always preferable to have a leader than a boss. So in the way that there should be a certain systematic way to assess how the resident is progressing. One should not give a cutting chances from day one. It can be like divided into 5 groups. One is exposing themselves to various preoperative and postoperative periods of the patient. Then slowly assess him how he or she will manage the patient in the surgery. Then letting him or her assess the surgery, letting him or her do surgery in front of them, and then letting him or her do surgery and teach their own colleagues. That is how my surgical curriculum evolved. So every 6 months, we used to have SR progress or a residence progress, where we will be listing the number of cases done. And I used to divide myself like A, B, C, D, E. E is just observed the case and A done without supervision. So every 6 months, it was seen that this much number of cases he has done under supervision, this much number of cases he has assisted, and so on. The second thing about mentor is with the number of increasing seats and nearly stable number of patients, the number of cutting chances is expected to come down. So they should elicit inquisitiveness within the resident themselves. Like each and everything they may not teach, but the kind of lecture classes or the seminars which they teach or they give the residents as homeworks should include certain topics in which they can go and search certain things from which they can learn new techniques and so on. So this is from the mentors or the assistant professors or professor side. From the residents' perspective, it's right time, ma'am, we should learn from others' mistakes also. We should start learning from videos also. We should have an opportunities to learn from dry and wet labs. And concentrating not just on cutting, but concentrating on patients. There is nothing wrong in staying in hospital for beyond certain time. During surgical residency, like we will never get back our internship, we will never get back our residency period unless the hospital environment is like exploitation. We should be prepared to spend more time with the patient themselves so as to be ourselves thorough with the patient both pre-op, intra-op, and post-operatively. So nothing wrong in staying for an extra time over there. And amongst colleagues,
can I interrupt and ask a question?
Yes.
From the student's perspective,
yes, sir.
The idea is not just to learn. The idea is to care for the patient. One of the statements I really like in Harrison's is the statement that the secret of care of the patient is secret of caring for the patient or care of the patient is actually caring for them, not just learning, not using them. And I think then at that point of time, overwork becomes a sort of joy. I have listened to, do you feel like that, or do you feel that whatever the resident does, ultimately it feels like an abuse? Is that true?
No, sir, that is not an abuse at all. I have finished my MCH. So I will take that as an example. During my first year of MCH, the time which we spend in our ward will be nearly for 24 hours, we'll be there for nearly 18 hours. So 16 to 18 hours. Initially, it was like a overwork for us. But once we cross that period, entered second year and third year, we realized that the first year was such an important thing, and only with the help of the time which we used to stay in ward, our second and third year, and now when we come and practice outside, is becoming easier. So definitely caring for patients is positive in both the ways for patients, and much more positive for residents themselves, particularly in post study practice.
Yeah.
And
yeah.
So coming on to this MCH or MS versus DNB programs, so definitely there are two different spectrums here. We cannot expect one to be like the other one. So even in MS, there are differences between national institutes, government medical colleges, and even in DNBs, there are certain standard hospitals which have a very strict curriculum, and certain hospitals in which the curriculum is not that strict. But this has to be ensured that there is a proper way of supervision, both from the national board and also from the professors or consultants in that particular hospital level. So that has to come. And curriculum
is that a fate or a chance in life that the PG gets a good teacher? Or
sir, I was very fortunate to have good teachers starting from my MBBS, MS, and MCH. So like I really didn't have to struggle during my 12 years of medical training. Had few like jitteriness during my initial period of practice when I started in a private medical college, but that's okay, sir. We have to cross this phase. But this is not the same for everyone. So certain people may not have a friendly atmosphere, but that is not going to be the same forever. In that perspective, the national board should have certain control over what is happening in each and every DNB institute or each and every MS or MCH institute. Supervision should come from there.
So there is a comment on the chat box. What's your thought on that? National board should allow only DNB programs where teachers need to pass the exit examination every 5 years. Do you feel your teachers are updated to the current knowledge, that they pass on the latest body of knowledge to you students? What is your take on that? And I would like the other panelists to also consider these questions.
There should be a certain sort of assessment program, though an exit exam maybe for a very senior people can sound a bit rude, but definitely there should be a means to assess whether they are updating themselves, and not just updating themselves, whether they are doing justice for the residents who are being trained under them.
Can you call Jaydat Pawar to comment on this? Jaydat?
Yes, sir. Am I audible?
Yeah.
Thank you, sir. Thank you for calling me on this panel. I completely agree with GDS, sir, in most of the aspects. Definitely, DNB program needs a great amount of inspection and also supervision. And like Sandeep sir said, there should be wet and dry labs for training. The thing is, there are enough labs in all the hospitals, but the thing is, they are open only during the inspection. That's the big problem.
You have any comments about anything else? Feel free to speak now. I mean, about the whole thing about surgical training, your undergraduation, yes. Then your residency and post-residency training, whatever.
Definitely, yeah. The thing is, the problem is from both the sides, whether it's residents or from the faculty side. The faculty complains that residents are not working, and residents complain that they are not getting enough hands-on. The thing is, we have to believe that each and every resident should be trained step by step. That is, you give something on a day 1, you give something on a day 2 and day 3, and then you ask him to redo the whole procedure once for all. You cannot give a resident knife and say you finish the surgery skin to skin and then scold him that you don't know how to do it. This has happened with me when I was doing MS. My consultant would give me the knife from the other side. He was on the right side, I would be on the left side, and he asked me to put an incision. And then obviously I would struggle because I'm standing on the left side, and then you would scold me that you don't know and snatch the knife back. So I think there has to be graded training. That is, you start from one step to another, then go ahead with the main procedure. And also I would like to mention that there are enough studies in UK where they have done studies regarding pancreatic resection and esophageal resections about outcomes when the resident do the surgery, and we are still stuck with hernia and appendicectomies. The thing is, because there is no practical based assessment
In a
whether
meeting.
the resident is improving or resident is not improving. And also, I would like to say there is no emotional connect between even the consultants themselves. I feel that the senior consultant, junior consultant themselves don't mingle with each other, and that is why they don't even care about the resident. And one more thing I would like to point out is the lack of responsibility. Like Pata sir said that a resident has to care for the patient. That is true. And also the thing is, if something goes wrong in the ward or wherever it is, the boss always scolds the junior consultant or the mid-level consultant, but never the postgraduate. So the postgraduate feels he is not responsible for anything. And that kind of attitude should change. Definitely, everyone is responsible, especially the postgraduate. Everything is not just on junior consultants or assistant professors. When I was working as an AP before this, postgraduate would tell me that a bed was fully soaked with blood and the dressing was not done. I asked her, why didn't you do it? She said, this is not my work, this is an intern's job. Such kind of people also exist. So we have to make sure that such people don't exist in surgery, I would say, because that kind of attitude is not going to help the PG or the patient. And like Pata said about his friend's son calling from Delhi, that I would definitely agree. In certain places in our country, definitely the training is extremely toxic. It's because not because of most of the senior consultants. I mean, at particular places, I'm being very clear in this matter. They are actually don't know. They are some are insecure, or maybe they had that kind of attitude change that we have suffered, and hence the juniors also should suffer. That kind of attitude shouldn't be there because we were not taught. You should also not learn. That kind of attitude shouldn't be there. It should be in fact the other way around, that we were not taught, so better we teach the next generations so that they are better, or maybe they remember them. And also some of the seniors think that we are some kind of competition to them. I don't think so that is true. If somebody teaches you, you respect them more rather than you compete with them. You want to become like them, you look up to them. And I think that kind of thing they should gain, because my boss in my PG, unfortunately he died because he was pretty old, and he was such kind of person that he would not let us do the universal precautional cases. He would say, I would do it, you are young, let me do it first, you can do it later. He would never let us touch all those cases. That we remember forever such people, because there is some kind of they make you feel so secure, they protect you in everything. That kind of connect should be there between a postgraduate and a consultant. That is what I feel.
Dr. Shenoy, would you like to respond to these two youngsters? Dr. Rajgopal Shenoy?
Yeah, good evening. Nice to hear Jayadath and a few others. They have given almost details about what is their experience and all. I'm coming from a private institution, so my post-graduation is quite long back. I don't think Jayadath or they were born that time. So what I would like to say is that firstly, any stress factor which you are talking about, the stress factors can be usually settled by a senior person. This is something which you should know. When you are in doubt, when you have got some kind of a thing, that it is better that you take some advice from your senior colleagues, or if not, obviously head of the department or whatever, because my daughter also has gone through this study period stress. It is not that so we all know that in institutions, number one. Number two, I somehow don't like when PG says that cutting chance. That word cutting somehow irritates me, for a simple reason. Every one of us, yes, we are interested to definitely know cutting, but what I would like to all the residents should understand that is the total patient care, as been already pointed out by Ilango, and each one's time will come. It's just that you see, you assist, you ask questions. There are different. 5 fingers are not same. 5 fingers are not same. Somebody, you ask question, he will answer. Somebody, he will go on operating. So during the surgical training program for postgraduates or assistant professors or SRs, whom you are assisting, some people will go on doing it. So it's better that you keep on asking. There are people who come out, on the other end, there are some people who will straight away start telling, this is how you do, this is how you do, this is how you do. And wet lab very nicely has been pointed out. Yes, as he rightly put it, it is there, but very often it is not used. Attitude, behavior, communication, there are so many issues related in a surgical training program as a whole. So in a private institution, the workload is not much, but I believe the teaching is better. But in a government institution now, workload is there, but I'm not sure about the other chances and other things. And India cannot be equated to UK or system, because UK system is a national NHS system, whereas here it is a mixture of private, corporate, government, and whatnot, nursing homes. So it is a totally a different system of education we are giving in India. You have a 100-bedded hospital, 20-bedded hospital is enough for a surgical training program, 30, I think, for a dependee. So there's so much variations are there. I think we cannot go on comparing all those things. My philosophy is simple. Try get maximum during that 3 years of training period. And I personally tell every one of them, it is not sufficient now. You have to have another 3 years of training till you go and settle outside, if you are doing only general surgery practice. Obviously, at the end of the 3 years, nobody will stop nowadays. If he's not stopping, he will be reading for MCH. So in a way, if you stay after 3 years in an institution, you will definitely get back to all your so-called the cutting chances, carrying chances, communication chances, your overall development to treat the patient as a whole. And surgery, as you rightly put, a surgeon should have like a family. You said no, professor does not talk to SR doctor. So it used to be a general common thing that PG does a hernia. Okay, I will go and have a dinner, and don't want to mention fellowship also. Yes, true. So I think as a whole, so many factors come into the picture here, which also can reduce the stress factor. There are some few comments. That's all from my side. Thank you.
Thank you, sir. VR, you're ready? We'd like to hear from you now.
Just a small point. Just a small point. I think.
Can you hear me? Hello.
Yes, yes, we can hear you.
Very respectfully, I've been listening to all the comments, and I just have a few thoughts. I have worked under pretty good surgeons throughout the country. During MS, I worked under some good people, and post MS, I had the opportunity to work from a very doyen of surgery, whom everybody knows in this world. So one thing I learned from sir, I mean, no harm in mentioning, I worked under GD sir post MS. Is that even in the best of units, people can be treated like humans. People can be treated with respect. And that is something which is hugely lacking in many programs. I find when I was a resident, I used to try to be a hardworking resident. I used to spend a lot of time in the wards, and when a crisis situation comes, we used to find that even some of the topmost consultants would not come to defend their residents, and that is something which is very pathetic in the entire system. And some of my best interns, people who were really brilliant and interested in surgery, when they got their ranks, immediately even after internship, all they said was, sir, why should I live a dog's life in surgery after getting such a good rank? And these are people who are really good in surgery. So at some point of time, I feel that we are losing some of the best minds to other specialties where there is an iota of humanity. And I wouldn't say this is just the consultants. It is also the senior junior culture. because once a resident is badly treated, we find that the resident who badly treats just keeps on repeating the cycle of abuse, the kind of words they use. It is I mean, far from being civilized. So we are losing a lot of brilliant minds if we don't reform the culture of toxicity. I don't need to tell people. People who are residents or even assistant professors would know that in certain states and in certain colleges, PGs are regularly slapped or even physically abused by seniors. And I think that is something which is very, very pathetic. I'm glad that this year, a lot of people do ask me, because I do guide a lot of students for their surgical counseling, and people were asking me whether abuse, for a lot of students this year, abuse itself was a factor. When I was working with GD, sir, it was a very hard-nosed unit. It was a very tough unit. It was a high-volume unit. If you didn't come prepared, you were likely to be punished. That is, punishment is very different from being badly treated. And at some point of time, if a resident works hard, there ought to be certain amount of reward. And I think it has already been spoken about. The increase in number of seats that people are just working as paramedics without having the chance to operate. And in many places, consultants, as JD sir often says, a person who is not fit to operate on an incisional hernia at 10 a.m. suddenly becomes fit to operate on a liver injury at 10 p.m. So people talking about supervision and lack of supervision. In many places, the resident is not allowed to do a single case in the mornings in the elective OT, and suddenly is left to take major decisions in the night. So essentially, this particular system puts a lot of residents, a lot of patient lives at risk. Forget resident life. So it puts patient life at risk. The other thing which it was about grief, and it was about the same. Currently, I'm pursuing pediatric surgery, and I took it after a lot of interest. When there is a sort of a patient death, the patient we handle the chemotherapy of a neuroblastoma patient, handle the entire the schema of treatment of the particular 5-year-old boy or a 6-year-old boy, and when we actually lose that patient to malignancy, the amount of grief we feel is immense. And when we talk about that we are feeling so bad, we are often asked to man up, or they say grow up there. So the kind of a toxic culture, you're not allowed to deal with your own grief. And slowly, what I found is that people who are unable to deal with grief, people who are the most emotional, they sort of become monsters at some point of time. I am not saying that everybody is not tuned to take grief. I am not ashamed in accepting that I have actually cried when some of my pediatric patients died. I didn't expect the residency to be emotionally taxing, other than being physically taxing. And at some point of time, if consultants can just say it happens, or we are allowed to express our feelings without the fear of being judged, I think it would do wonders to the mental health of the entire profession. The other issue with which we often deal with is the increase of seats. A lot of people taking surgery. I wouldn't say the fault is entirely on the system. A lot of fault also lies with the resident at times. A lot of people taking surgery are people who have just gotten surgery rather than being interested in surgery. So a lot of the problems occur because the residents themselves are not interested in surgery. I have seen certain residents spend time in stock markets in the mornings between cases, when they could have actually taken up a book and started reading what about the next procedure. So I think the onus lies on both, but the current system of toxicity and the overall administration, which is rapidly increasing the seats. In Hyderabad, there's a college with 40 US general surgery seats. So all these things are essentially making surgical training unattractive. Thank you.
Dr. GDS, sir, would you like to respond to that? Do any of the other panelists want to add or?
Hello.
Yes, sir.
I fully endorse the views of dear Vinayak. We had an opportunity to be together for 3 months when under the banner of LGS, we started a fellowship of communication skills in general surgery residents. So he spent 3 months in our unit as a fellow for primarily communication skills. Surgery was incidental. See, what is lacking is a human component. And till it has to come from within the teacher. Unfortunately, in all DLB programs, when I interview people for when they come to the classes, I hardly find a place which has a regular structured program that Monday we will teach this, Tuesday we will teach this. The residents are treated only as workers. They do the same thing as first year and they do the same thing in third year. So inhuman treatment. And the other point I mentioned in comment also, the inspectors from national board are also indifferent. They should not permit. If all the residents tell them that in last 1 year we did not have a single class, I don't know why they allow that program to continue. I'm a bit loud on this issue, but I find the, residents silently suffering. And we should program of longer too. I fully agree with Professor Dhar. Long ago, CMC Ludhiana had minimum 4-year program. Boss never allowed us to appear before 4 years because he said, if I allow you to appear after 3 years, and Indian system of examination is such that you may pass by telling the classification of lipomas when you cannot do one. So we were minimum 4 years he allowed to appear. And whoever left after 4 years, he used to say he was a resident here. And more than half people continued for 5th year. Then he would say he was a surgeon here. So surgical learning takes time. Many people who want to do SRship also do not get a SRship in a proper department. Everybody wants to learn. There's nobody who passes the national board on merit and joins a program has not come, just to pass time. So when I always say, when a resident fails, it is equally the failure of the teacher. We should take only, my call to the teachers is take the most, the guy who is the lowermost on the rank and push him up. Making a person who is already in All India Institute, he is already 95%, making him 98 is not much of effort because he is self-driven. Pushing somebody from 50 to 80 is a great achievement. So let us target and push those who are academically and otherwise down. It is also a good practice. On my Sunday rounds, there has been a tradition that after the teaching round, we have breakfast or a coffee or some snacks together and ask people how is their wife and how is their girlfriend, and if there are any problems anywhere in their accommodation. And these small gestures add diesel to their and adrenaline to their work effort, and they work better, more patient care, and so on. Thank you. If there are any questions, I would like to answer.
Jaydat, you're saying something when somebody took over.
Yeah, I think he typed his thoughts on the chat box. What Jaydat felt he's.
Yes, I did, sir. I did.
Yeah.
You can enumerate them. Yeah, it looks.
It was about Shenoy, sir. He was. I was working with him in Manipal. I remember he would write the names of the people who would do the case on the file itself. That this is a PG's case, this is a resident's case, this is a AP's case, this is a senior resident's case. So I think there are such people who exist. Sir was telling me just 5 minutes ago that it is not possible to follow UK system because there are many players involved in our medical system. But there are a few people like him who are doing it in a private deemed university. So I think there is something to learn from him as well.
Jaidat, you said something about the junior consultant and senior consultants in their chemistry, but what about the chemistry between the postgraduates themselves? Somebody was commenting about misunderstanding, violence, this, that, and the other. What is your experience in this? Should that be corrected to some extent? That camaraderie between postgraduates, male and female postgraduates, some understanding and so on.
Definitely, sir. I think in general, as surgeons, we have lost that human emotional touch. We are just into this race of becoming the best surgeon, becoming the best resident, they're becoming favorite of the boss. And many of the people think that within 3 years they're going to learn everything and get the highest number of cutting chances, and as soon as they go out there is some heaven waiting for them. But that is not true. No matter how many years you're in surgery, every day it's that's what I feel. Every day it's when my boss is struggling, I realize that even after 30 years any case can be a difficult case. So we have to give room to each other, we have to let each other grow, we have to be good to each other. Only then we can achieve something. Because as you can see nowadays, the group practice has already begun. I've seen even in Delhi that many surgeons would ask another surgeon to help them during major cases, so that they can share some responsibility and as well as have some different perspective if they're stuck in the middle of the case. I think that would work better. We shouldn't be too selfish, and there is always someone better than you. No matter how great you are, there is always someone better. That's what I feel.
Sandeep, we had to kind of cut you off while you were speaking in the beginning. Would you like to add something to what you said in the beginning?
Yes, ma'am. I also wanted to propose a system of qualitative audits for various teaching programs. So all the teaching programs, so what currently students are selecting institute is by the means of their face value. So because AIMS is a big name, that's why residents are
Yes,
going to
1 minute, Sandeep. Patta, can you please silence? There's some lot of background noise.
Yeah.
Yeah, thank you. Sorry, Sandeep, go on.
So what I was saying is that a person who joins AIMS, he is not joining AIMS because he will come out as a good surgeon. He is joining AIMS because of its face value. It is a premier institute. It is institute which is talked most in the news. Okay, but if I go to AIMS, sorry to all those who have been trained in AIMS, but the cutting, I'll again not mention cutting chances, but I'll say operative chances given in AIMS to general surgery resident are next to nil. It's like skin closure mostly, and layered closure, that's it. So I want to say that there should be a system of qualitative audits, whether a government agency or an extra government private agency which can rank these institutes, or at least an informal way by which learning general surgery can themselves form a anonymous system of rating, whereby all the residents can rate based on objective laid out criteria: how many wet labs, whether active wet labs are there, whether operative exposure is there or not, and what level of operative exposure at per year is given, whether the operative exposure is divided between the hierarchy of the residents. So these kind of objective criteria can be laid down, and this kind of a questionnaire can be given to the members of learning general surgery, and based on that we can come out with ranking of the institute, and that will be the actual ranking where you will come out as a good surgeon. So this kind so a person who has this ranking system, he will select the institute based on the actual value of that institute. So this is one solution I wanted to suggest.
That's a very good one. We can have our own internal ranking system, and probably it will start a competition among ourselves, so that we see our own institutes coming up on the rank, peer-reviewed ranking. That's a good idea, Sandeep. Theodore Bilroth, you have a lot of, you've got a very good points on the chat box. Would you like to actually speak about them? Theodore Bilroth?
Yes, ma'am. Good evening. I am a Central Institute pass out in the last. I passed out in the last year, ma'am, like 6 months back. So it's a very popular Central Institute. I'd say my training was very good regarding the basics, and I learned a lot of things. But as respect to the hands-on training, when it comes to surgical hands-on, I would say it is quite poor, and most of the program they don't actually have any baseline or any number of surgeries that you should be confident in once you pass your MS program. I think that is very important, that if you are getting an MS degree, you should be confident in few surgeries. I have assisted a lot of cases, but I did not get to operate many cases. I think hernias I've just operated 2 open hernias, perforations, two perforations. And it was basically like slavery. We used to get the cases ready, and most of the time it was done by SRs. And also the bad thing was that most of the SRs were DNP candidates, and it was such a pathetic state that when I joined in first year, the DNP candidate who was in second year, means he was the second year SR, was not able to open the abdomen. So that is the kind of situation in some of the institutes, even in central institutes. I would say this is not the main central institute, this is the other central institutes which have come up newly. So I would say that the faculty should make sure that they supervise, because they are present most of the time in central institutes. They are present from 9 to 6 or 7, and they are already always interested in doing like complicated cases like colonic transposition and all. That's fine, we are assisting them that. But I feel that until and unless you do as a main surgeon just a few number of cases, I'm not saying Patta sir had put in the group that how many cases of lap hernia you have operated. I think that is too much, sir, but at least you should be able to put the ports in case of like lap chole or something. That is what is required. I am not asking for lap hernia, it's too much, it's a very complicated surgery. So a basic set number of surgeries have to be written down. The scrub list has to be pre-marked the day before the surgery. And also the attitude of like the mental health issue which we are talking. Some of us are fine. I read a quote by Ilongo sir. He said that when the student is ready, the mentor appears. But we have work, sir. In my first year, I had a sleeping bag that I used to carry in the casualty. I was sleeping in the casualty, and we have taken showers in the in the hospital. I used to not go back to my room. I used to stay like 3 to 4 days inside the hospital. But I am quite disappointed with. I sometimes regret that probably I had a very good seat in my state medical college. I should have not chosen Central Institute, but it was a memorable 3 years. There were very fine senior residents. There was not much interaction with faculty. They were like in their own, they were doing their complicated cases. There should be more interaction between this. And that is what I said. Like if you are passing out with an MS degree, there should be some cases which you should be able to do at least confident. Not very confidently, but you should be able to do this. Basic cases. So this is what I would like to say.
Your point is very well taken. I think Dr. Girjadhar Sharma has repeatedly mentioned this. Ilango, what would you like to say about this? Very valid point that our friend has raised here.
Yeah, it is true that that I often say that when the student is ready, the mentor appears. I sympathize with you, and I can understand, because I did not go through a central institution training. I trained in Trivandrum Medical College, and then subsequently in Madras Medical College. They were good institutes, and what we did, it is not, there's a lot of difference in the way we trained. Madras Medical College was, I worked under 3 different professors, and each one of them had a different style of working. The trick was to get the best out of each one of them. It's not that everybody had only negatives and only positives. We had Professor Sri Kumari Damodaran, who was an encourager. She would sit outside and said, "Boys, you go ahead and do it, put the blame on me." So we took care that we did the right surgeries, made the right decisions, conveyed the message, and made sure that our patients were well attended to. Professor Ratnasamy was very much hands-on. So he would round with us, take us through the individual decisions, help us with the surgery, assist in things. And if he does not know, he will get a specialist to do the surgery for us, demonstrate and stuff like that. it was a different learning experience. Professor Chandramohan was a different one. And most important, they made opportunities and platforms for us to meet people like Pattarada Krishna. A lot of surgical GE platforms were opened up for us. So what we did was we made them teach. Like if we wanted to do a colon, we will flood the list with pancreas cases. So obviously one table will become free for colon. So it was a sort of mental manipulation. And I think it is the same thing which I did in transplant surgery as well. Dr. Humar's work needed me to stay in the hospital for long hours. So he would do his last telephone call to me at around 11 p.m. And sometimes he would ask me to review the patient. I would go back, see the patient, update, review everything if I have to see them physically. For that, he gave me opportunities for me to operate. So it worked like that in the US, and I think it works like that in India as well. So you are in the early stages of life. My father, when I finished general surgery, MS, my father said, no, just because you have the word master of surgery does not mean that you're a master in surgery. Just the degree just means you're a good student in surgery. One of the key things that young surgeons should never forget is that this is a lifelong commitment to learning and excellence. So you cannot just finish off and then everything will drop into your lap and you will transform your life. We really empathize with your feelings and the way things are. We are very hurt by what we heard about your mental struggles. And we would work very hard as teachers to make things better for you. I recently had a young doctor who just broke down and said, sir, do you have any complaints against me? I said, normally I don't complain against junior doctors to anyone. And she spoke of the abuse she endured under one particular person who would just not talk to her, not give instructions and keep them on pins and needles all the time. And that just broke the young doctor. So we encourage you to talk to us, all the faculty in LGS. We are very much open to help you out. And if there are things that we are unable to help you out, we will find you the person who will actually make a difference in your life. Surgery, as I said, is a lifelong commitment, and it is a way of life. So you might have to make changes in your life. And please do understand that if you do not have opportunities in 3 years, does not mean that you will not become a good surgeon. The opportunities are really plenty in the real world. And I think we will encourage you to be open to us so that we can actually learn what matters for our students and how we can train the next generation of surgeons. There is a selfish motive from my point of view. I always feel that if we train the best, sometimes I may need to undergo to be under the knife in the future, and the one whom I have trained would be the best to do the surgery on me. And that's how I feel. Personally, I don't feel anything competitive. And we have a bunch of young surgeons in our hospital. It's a corporate hospital. We have a bunch of young urologists. We have a bunch of young surgical oncologists, and some. I would say I am middle-aged. I'm close to 50 now. So I find myself going and helping them and assisting them, and the joy of seeing them accomplish something is something that cannot be substituted. The greatest learning as a teacher for me did not come from doing many standard Whipples or a standard appendicectomy. I would just get the standard procedures done by junior-most people, and the way they struggle actually polished my surgical skills in diagnosis, problem solving, and I became a much better surgeon by just assisting a much junior surgeon to do his regular appendix. The same I have seen with many people. See, I learned from some very good stalwarts, and I was very fortunate to go and learn specific surgical tips from surgeons. And at each point of time, they would come over and assist a much junior surgeon, and that actually brings their skills to an excellent point. I learned pancreatic surgery from Dr. Ramesh, and at a point in time when I didn't know anything, he was there patiently demonstrating every step of Whipple's and other pancreatic surgeries, and I still carry them with me with like 13, 14 years. I was not a student for a long time. So for the teachers, I think we learn best by teaching others. I think that's what makes us best. Those are my comments, and I'm open to more sessions like this for you to open up and tell us what you actually need, so that we can work together and make a difference in making surgical training in India much better than it actually is now. Over to you, ma'am.
Right. Radhakrishna, you wanted to say something at this point?
I want to say a lot of things, Vidya, because I've been through a very good, extremely good training system, and also a not so good training system. I could make out the difference. What people keep talking about hard work, and and there's a lot of criticism when I wrote about the long hours I worked, and somebody said, no, this boss should be put in his place. How can he make the residents work like this? But I think hard work is necessary in every registrar's life at some point of time, because in state medical colleges, most work gets wound up by 3 o'clock, 4 o'clock, but in central institutions, not so. Hard work is very, very necessary. And actually, I had a couple of years ago, I had 2 assistants working with me. Both of them are central units trained MCHs. If they're in the hospital beyond 5 o'clock, means some patient is not doing well. I mean, you need not tell them anything. They do their round and they find that some patient is not doing well. They're just bedside and they'll just keep thinking about how things can be made better. They'll not think about dinner. They don't think about going back home. These are all some very special things which people learn, because they don't just wash their hands away and think, okay, the night duty person will take over. This dedication is something which really touched me. And I think there are a lot of room for such things in some very good central institutions, because that's how you develop discipline. And one important thing I always thought is, if you're good, if you're sincere, you will get your chances. If you're people notice, because I've always seen that the seniors keep noticing that who's doing what and who's just appearing at the time of surgery, but the rest of the time roaming around whatever. So hard work definitely pays, and that's one thing we should be very, very particular about. And the second important thing is, I personally feel, at least from the colleges which I had my early education, there's not so much focus on journal reading, learning statistics, and research atmosphere. I don't know whether it is any better now. A few central institutions focus on this, but at MS general surgery level, we were not so much into it. And another important thing I always want to tell my students or who are work with me is that there should be some standardization. In a unit, general surgical unit, there are 5 consultants, 6 consultants do bowel anastomosis in their own way. And it's very difficult for the student to learn which is the right way. So in the Delhi unit where I worked for long, and Dr. Nandi's unit, everybody should follow the same step. Everybody should use the same suture. Everybody should make an anastomosis only that particular size. This standardization is very, very important, and I think every institution should have a standardization of that nature. So automatically, when you grow, you follow all those, and those who follow you will follow them. It's that way. Now, otherwise, trying to do various techniques and keep changing technique every surgery is something which one shouldn't do. There are many such things, gems, what you need to learn from surgical units, and I think that you should gather as you go. This is a wonderful, neat and wonderful place to exchange ideas. And actually, for the first time, I really saw some real strong responses to some notes I put up in LGS, and I really felt bad. I really felt bad to see that the many people have hardly done any surgery in their training period. Vidya.
Yeah, so that coming, how do we, I mean, I think the students would
okay, now if I can ask Dr. Rajgopal Shenoy, that now we have come to a situation where the students are so many, the cases are very limited. What solution does he find, and in what way students can be happy? Do you have any formula by which we can redistribute this training and the cases and their training?
The only one or two thing which is since I am working in a private institution, I would just like to give some information that the post in the new NMC document, the PGs who are posted in the private medical colleges also should work in government medical colleges when they go to final year. I'm not sure what exactly, probably they will also get some better chances of whatever doing surgery or what. I understand in that way, number one. Number two, they also help the government. It need not be a government medical college. It can be a government hospital, which is a district hospital or whatever way you can call it as. So it is a mutual benefit. So postgraduates are available to do the duties also there. At the same time, they will also assist. I personally feel it is fine because there is absolutely nothing wrong. It's like clapping, both are benefited. It is a fine. Second, the point which Jayadath had told first one, that is that wet lab. See, that is the one which has to be seriously implemented in all the medical colleges. So that is where is the training, because now including ours, most of the medical colleges, obviously government and all, we have 21 postgraduates now. So, and this year, interestingly, this February 21 joining, 6 are remaining now. And June, there is another 21 because of the last year's quota. So this COVID batch 21 plus this year's 42 will have a real serious issues about the opportunities, learning, the training, everything. So I have no solution other than, as you rightly put it, I tell the PGs, get the best from whatever you can get from your each colleague, maybe junior, senior, professors, teaching, and wet lab is only the answer for that. And the operating chances, I'm very clear, whether COVID or no COVID, last 10 years, I have been observing this. It is 3 years is not enough, as rightly put it by Long or somebody. It's just a driving license. You have got a driving license now at the end of 3 years, and remaining 3 years you spend in the department if those who want to go for a private practice or join. Otherwise, they will go to super specialty. I think I'll stop at this level.
Yeah, thank you, Dr. Shenoy, for your comments. Dr. GDS, sir, your closing comments. We are almost been here for 1.5 hours.
I think we have discussed most of the issues very well. This is an unending discussion. We can only suggest the faculty around to make the local changes and decisions, as we have discussed, with increased number of residents. There is also a decreased inflow of patients to medical colleges because of increased number of private hospitals where public has more faith and accessibility. So considering all these factors, as Professor Shenoy said, more time spent in, I would use the word, more time spent in wet lab under supervision is the only way to train people hands-on, so that when somebody has done anastomosis around 10 times on wet lab, then there is an opportunity to pass on one to him if there are patients to be done. And helping people on all developing their skills besides surgical skills. Total patient care. I find nobody who was involved in pre-operative, post-operative, and comes well-read to OR is not passed on the cases. People only currently want cutting, and nobody knows past medical history and past surgical history. So documentation is forcefully created of their own. Most DNB hospitals have very poor documentation. It only says known patient of gallstone admitted for lap chole, financial clearance done, PAC done. I mean, this is the level. And whatever one may try, this is uniform. I can say all hospitals in Delhi I have seen personally, despite of saying people don't want to write anything. And then suddenly one day they want to present a long case in exam and pass, which does not happen. So we can have more interactions, we can get feedback, but we cannot mend national board and the policies of the country. We can ourselves have local modifications to improve our systems with the friendly feedback from the residents. That's all for today. We can meet again on a similar topic. Thank you, everybody.
Thank you, sir. Thank you, sir. Thank you, Anjali, Jayadath, Sandeep, Santosh, Theodore, and VR for logging in and being so upfront and really discussing the problem, and also accepting that there are two sides to the problem, and it's not just that all the trainees, everything is fine as far as the trainees go. The problem is with the trainers or the system. So thank you very much. Ilango, did the session go the way you wanted? Do you think we've got enough thing to take this forward?
Yes, I think we would like to have one more session with the students, and we would actually encourage everyone to participate. You can participate anonymously as well. And please share your thoughts. We really want to make a difference for you. This is an open platform for everyone to express, and I think we will be able to make a difference only if we push this thing together. Thank you.
And I cannot thank senior teachers like Dr. Rajagopal Shenoy, Dr. Punithar, and of course our own GDS sir for sparing the time and being here for 1.5 hours. That shows the students, that shows how seriously the teachers are taking your words. So like Dr. Ilango said, please continue with your feedback, and we will plan another session a few weeks down the line. Ilango, what are we doing next week?
Next week is thoracoscopy.
Yeah, we have a session with Professor Arvind Kumar. GDS sir is moderating this session, and we'll give you more details on it in the coming week.
It is the scope of thoracic surgery as a professional career for young surgeons. So it's a growing branch. And Professor Arvind Kumar will highlight the pros and cons and the developments and the scope, taking it as a specialty.
Thank you, sir. On Thursday, actually, this Thursday's episode of Marvelous Medicine happens to be a very surgically oriented topic. So a medical gastroenterologist, Dr. Usha Datta, will be discussing on whether all gallstones need to be operated, and can we stop the progress of from gallstone to malignancy. So I expect a lot of you surgeons to log in on Thursday. That's 2 days from now at 8 p.m. for our this week's episode of Marvelous Medicine. Thank you all for being here. Take care and stay safe. Good night.